Okay. Welcome back, everybody. I can't believe, as Steve just said, it is Sunday. It actually is all day, I guess, right? And here we are. So glad to see you all. As we were just saying, it's been so wonderful to have this support mechanism, both here live and those who watch after on YouTube all these months. Glenn, how many months has it been, right? It's really very, very hard to believe. And we are so grateful for all that you do, both with us here on Sundays and during the week. And thank you to everybody who has sent in questions during the week and will be trying, hold on one moment, I'm going to mute. Glenn will be talking tonight. He's going to take us around the country and around the world. He's going to be talking about the news this week, about the different vaccines and what we can expect, and talk about the different holidays coming up and expectations and families and friend gatherings. He's going to talk about carriers, people being silent carriers, and super spreading, that kind of thing. So before we jump in, I want to just also remind everybody, if you have questions during this discussion, please send them directly to me and I will try to weave your questions into our conversation. If not, I will send them to Glenn so that he can address your questions next time. So, Glenn Grossman, our esteemed host, is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, CDC, and other programs in the United States and abroad. Let me just mute. Okay. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So Glenn, as we usually do, we usually kick off the evening. In a few minutes, you take us around the country and then around the world. So take it away.
Thanks, Rebecca, for that great introduction. And I apologize, it's raining kind of heavily here now, so hopefully it won't be too distracting for this. So let me make this a shared screen. All right, so basically, I saw this and I kind of laughed when I saw it. Here's the current dashboard. No, I'm kidding. This was actually, I'm not so kidding. This was published in the I think it was the Wall Street. No, this was foreignpolicy.com, and whenever you do a dashboard like this and it's all red, it doesn't really inform you about anything. So I don't know that this dashboard is so good, but let me go into some of the weeds in terms of where we are, and then we can talk about it. All right, so things are getting really bad though around the country, and virtually every state is in bad shape. So when you look right now, you see that we're on an exponential growth curve, and so without drastic measures, we are not going to bring this down. There's parts of the country that are in really bad shape, but we're back on an exponential growth curve. When you look at currently hospitalized, over the summer peak, at roughly the peak at the number of people hospitalized at any one time roughly hit the same peak as the first peak back in March or April, but we're already exceeding that. And I'll go to the dashboard online in a second. When you look at daily deaths, so we hit over 1,500 daily deaths a couple days ago, and we hadn't seen that level since the middle of May. And things are only going to go and get worse from here. So we need to talk about this a little bit more. As I've mentioned earlier, there's a regional variation that was sort of hiding some of the differences over time. So in the Northeast, we got hit really hard in March and April, May. But in other parts of the country, they didn't get hit quite as hard there. Whereas in the summer, the South got hit really hard in the West, whereas the Midwest and the Northeast were not hit quite as hard. But now the Midwest is getting really slammed the most, but we are seeing increases across the country. Let me look at my website here. All right. So when you look at the number of currently hospitalized, it's still going up. I mean, this curve is going up very fast. And each day there's more than the next. The difference between the currently hospitalized and the daily cases are that the daily cases are unique patients. So the people diagnosed on November 9th are going to be different than the people diagnosed on November 13th. So it's all different. Whereas currently hospitalized, a lot of the people who are in the hospital on November 2nd are still in the hospital on November 10th. So they're the same people. But it's important, and the reason that we look at it as currently hospitalized is because this is looking at capacity, hospital capacity issues, and the how it's hitting our healthcare system. So it's really important, and you see that we're on our up curve, and it's just going to continue increasing very rapidly. The deaths are also increasing. One thing that you don't see here, which I really wish we were doing a better job of capturing, early on, back in March, April, deaths were really an important outcome, and they're still an important outcome. But I would say now we know so much about the disease, at least as important is following people after they've been hospitalized and after they have been infected, because we know that a lot of people, a fairly large percentage of people who have had severe SARS-CoV-2 continue to have symptoms for many months after. And so this is something that people aren't really talking about that much. And I'm talking about impact on lives. Like, so for instance, not being able to easily climb a set of stairs to go upstairs without getting winded and severely having impacts to life. And so this is something that we don't know how long this stuff is going to last, the duration of these things, but it's this in some ways, in terms of the population impact, is at least as important as the mortality component. All right, looking at some other things here. I'll get into this in a second. Well, no, I can jump into this now. So I like this. So I've started looking again at the New York Times maps. They update these maps regularly on the coronavirus restrictions and mandates in all 50 states. And so here's where we currently are. In most of the country, there are not closures of businesses yet, except for New Mexico, which seems to have a bunch of businesses still closed. There's some mixed closures in in a bunch of states around the country. When it comes to masks, you see that there's far more widespread mandatory masks requirements. And so not all of the country, in fact, there's a bunch of places in the country where there's no restrictions at all. But you see that in much of the country, it makes sense that we should at least have mask restrictions. In terms of stay-at-home orders, there's currently no stay-at-home orders, but in Puerto Rico, there seems to be something. I haven't been following it closely. But we are going to be hearing additional curfews or other things going on. So there are currently some advisories in place, but we have no all-out stay-at-home orders yet, like we did. All right, let's go and talk about, I wanted to bring up Sweden temporarily. So we had previously talked about Sweden, where they had not had a shutdown order, and they really burned through the population. And by that, I mean a lot of people died. So for instance, when you compare, let me compare Sweden to Finland and to Norway. I like doing these comparisons because they are just adjacent to each other, and they're very similar in terms of the population dynamics. So you see that Sweden, at first, at the very beginning, had an uptake curve very similar to Norway's. Norway shut down, oh wait, not Central African Republic, I need Finland. For some reason, Finland is not coming up there. All right, now Finland is coming up. All right, so Norway and Finland, they both started having outbreaks. What they did is they shut down, and Sweden did not shut down. Sweden continued to have this outbreak that just persisted. It went up and down at some points, but it just continued to burn through the population. And their whole reason for doing that was they claimed that if they did this and let it go through the whole population, that there would hopefully be a herd immunity that would start to develop in the population. They never actually declared that herd immunity was something that was their key goal. In fact, they were very, very careful to play with the words that they used, but at the same time, they did make it clear that it was consistent with their approach, and they would expect to see a decrease back in the fall and winter when other countries would see an increase. And in fact, what you see is just the opposite. Sweden is back on an exponential curve here, far, far worse than we were back in March, April. It's different now, so you can't, across all countries, we can't really compare the total diagnosed people here with the total diagnosed people back in March and April, because there's far, far more testing now. What we can compare is week over week. So these numbers are very accurate week over week, and we are seeing, and across countries generally. And what we're seeing is that Sweden is far, far worse shape. When you look at the confirmed deaths, so Sweden, they just had a lot more deaths. In fact, it might be easier to look at cumulative rather than 7-day. So you look at the total number of people as a percentage of the population that died, or relative to the population. This is per million that died. Sweden had far more, and now it's starting to increase again. So it's in bad shape. So the whole idea of this going for herd immunity, it's not a good idea. And we'll hopefully get into this idea of vaccine herd immunity versus natural herd immunity in a little while. All right, so yeah, so I mean, I laughed before about the dashboard, but it actually is pretty bad when you look at it by almost any way. We're looking at this here. This is the test and trace dashboard in terms of the ability. So there's two main things it looks at. One thing that it looks at is the percent positive test rate. And so that we aim to have that as low as possible, under 3% for sure. And in much of the country, it's pretty high now. Pennsylvania, for instance, what are we looking at? Is a 22% positive test rate, which means it's out of control. New Jersey has turned red. New Jersey's positive test rate is around 9% and climbing. And so the contact tracers, there's no way to keep up. In fact, this is represented here. Ideally, contact tracers, there should be approximately 5 to 15. The more the better per positive test. And now we can't keep up. There's less than one person for each positive test. In fact, there's approximately one contact tracer available for 2 positive tests. And so there's not enough staff to simply go and do all the contact tracing of who might have been infected and where they might have gotten it from. And so as a result, there's no way now to keep it down from contact tracing and testing. We're going to have to do much more severe restrictions in New Jersey and other states. I think a lot of states are going to avoid shutdown as much as possible, and we'll talk about that in a little while. Next, so this we looked at before. This is pretty bad shape. So this website I like, and we haven't looked at it in a few weeks, but this basically, the criteria it uses for its dashboard are the original criteria recommended by the Trump administration for the CDC. Some of us had worried that this was too generous. It wasn't constrained enough in terms of what we should be tracking and making sure that things were okay. But yet under the definition provided here, this is what we see. So after the election, some people thought maybe SARS-CoV-2 would just disappear, and it has not. And we're in a season that it's going to be where a lot of people are going to be in trouble with the disease. All right, let me share a couple of things. So that's enough for now, unless there's any particular questions. I want to just go to a couple other things. So one is this. So I've shown this map previously. You see that the number of states. Oh, let me do this comparison because I think it's useful. So here is, let me just do Europe, United States. All right, I'm doing confirmed cases, 7-day. All right, so what we're looking at here, I mean, Sweden is still very high here. So here's Europe, where Europe is. Their average is around 350. Sweden's at 400. So this is cases per million. So here's per million, cases per million. The average in Europe is around 350. And so some in Europe are higher, some are in lower. When you look at France and Spain and some of the big ones, Germany, let's put them up. You can see that France was high, Germany is still increasing, but a lot have gone on lockdown. And so what this means, let me come back here for a second. So here are the cases per million. And so much of Europe has gone under lockdown. Remember, the United States is not in this alone. This is a global pandemic, and seeing how different countries respond is informative because it enables us to see how well we're doing relative to other countries. Because there's no excuse like, oh, well, any leader would have done this or whatnot. We have examples because every country is dealing with this in some way. So what we see here is Europe went under lockdown. It varied across different countries, but within the last few weeks, some countries got hit really hard. I'm looking at Switzerland, Czech Republic, what is this, Belgium. And so the maximum they hit was around 1,300, and they all shut down just when they were nearing that number. And so this was reasonable. Once they start getting to high numbers, you shut down. And so in contrast, look at and I want you to pay attention to the numbers that we have here. So roughly by 1,000 or so, that was when the highest of the high in Europe were shutting down. But Europe on average was mostly closer to 400 or so we were talking about. In contrast, we have, I think, what is this, 9 states above 1,000 currently with no talk of shutdown. In addition, we have a lot of other states that are not above 1,000, but are very close. Look at all these states above 800, 900. Rhode Island even was above 900 for a bit. This country is not in trouble. And the states are making a conscious decision not to shut down right now, despite the fact when you look at other countries, they have made the decision. So this is a choice. It's not we're not in this alone. If each of these states were their own country, these would be the worst hit countries in the world right now. All right, I talked about Europe. Even after Europe shut down, and you see how many national lockdowns there are across Europe. Even after Europe shut down, the death rate continues to climb after because once people get infected, it takes a while between the time it takes when people start getting asymptomatic to minor symptoms, to more severe symptoms, to hospitalization and death. And so the death rates are now just starting to go down a little bit, but you can see that some of the death rates were pretty high. All right. In terms of where we're going, so let me just say right now, in terms of deaths per million, this is a little bit outdated. This is from November 9th, which seems like a long time ago now. But in terms of the deaths per million, there's at least 4 or 5 countries over 8 deaths per million. And the reason that this is important is I'm about to show you of some of the models in terms of what our expectations are when states would be shutting down. And the models are all built on this assumption that any reasonable state would shut down as soon as it reached 8 deaths per million on average from SARS-CoV-2. And yet we're finding in real life that they're not shutting down. And so that means that one of 2 things: either they're going to shut down any second and we just don't know it yet, or that the total cumulative deaths by January 20th, let's say, as an example, are going to be far, far higher than predicted in the model I'm about to show you. All right, so I just showed you this. This was from a day ago. Same type of thing. This is the masks mandates that are currently in place. Let me take this and copy it and put it on the next slide. So the reason I'm doing it is because these two graphs are telling us slightly different things. So the graph on the left is the one that is telling us this is the reported mask use. So the one on the right is the mandated mask use. And we know that just because there's a rule in place doesn't mean that people follow it. So surveys have been done to look at how many people are actually using masks. And when you ask with the surveys, you see that there is some mask use that overlaps, but there's still a lot of states that are like, so for instance, look at Louisiana. Technically, there's mask mandates in place, but look, there's there's a lot less masks actually being reported as being used. And so what this means is that unless other ways are found of getting people to wear masks, then the numbers are just going to continue on an exponential growth curve. And in much of the country, even without the ones wearing masks, there's a lot of people who are reporting not wearing many masks very often. So and you see even in this area up here where there's mandates in place, there's a lot of states where there's just not a lot of people reporting using masks. And unless we get to like almost 100% mask wearing, we're in trouble here. So anyway, this is what's used in the projected model. Based on this, this is the projection. So this is the projection of when states will lock down. Again, this is based on this assumption that when states reach 8 deaths per million, they will lock down. And we already see that this has been violated, this assumption of the model. What that means is that the projections I'm about to show you are likely to be too low because people are going to continue to die at a much higher rate. The problem is here, let me show you this. So this is the current US lockdown. This is not projections, this is actuals. So this is the deaths, the reported SARS-CoV-2 diagnosed deaths or COVID-19 deaths per million. And so it allows us to compare across country, across states, across everywhere, even if there's different population sizes. And so there's currently 4 states as of a couple of days ago, although it's starting to rise some more. Montana, North Dakota, South Dakota, and Wisconsin. You'll notice if North Dakota and South Dakota don't shut down, right now they're on track to get to levels that we saw back in New York and New Jersey back in March or April. And so if they don't shut down, there's nothing to keep them from just keep continuing to get more and more deaths. And so if their death rate goes up, so if they continue to get more and more deaths, then the projections are too low. So right now I'll show you the projections and then I'll go back to the states. So the current projections on the track that we're currently on, assuming that states all shut down if they hit 8 cases per or 8 deaths per million people, assuming that the states are going to start shutting down any day now, we'll hit 400,000 deaths, total cumulative deaths by around January 20th, by the beginning of February. If we have universal mask use, not universal mask mandates, actual universal mask use in all the countries, then we'd expect that it would reduce the total fatalities a dramatic amount by February, and that we'd only see around 350,000 or so. So we'd save 50,000 lives by doing that, but that's unlikely to happen. The worry is that if we continue to see what we're seeing without shutdowns, then the numbers are going to follow this projection curve. And by February, rather than 400,000, we'll be hitting closer to 500,000 or more deaths, total deaths. So this it's not in addition to what we've already seen. It's including the deaths we've already seen. Some of us have noted, like I've noted previously, that there's an undercount of deaths that have been going on for COVID-19 for a variety of reasons, and that even though the total reported deaths are one thing, my best estimate is that we've exceeded 300,000 COVID-19 deaths already at the beginning of November. And so I believe that this curve doesn't actually represent the number of deaths we've already had. So here's November, and so I believe we've already hit over 300,000. What this means in terms of the projections are that we'll hit over 2,000 deaths per day by January is what this model is saying. But as you saw, we already hit 1,500 COVID-19 deaths per day by early November, which was by here. And so that would have been over here, up here on the chart. And so the model you can see is not necessarily even keeping up with how fast things are getting bad here. There's a variety of reasons. I can get into this in a later week because there's so much else to discuss today. But at first, before I go on out and leave this, I'll just share two more things. First, I'll share how this projection compares with others. So some people have criticized the IHME, the Institute for Health Metrics and Evaluation, their model in the past. I think that generally it's been about right. They just over the last few days corrected their infection fatality rate to represent more of what it was like over the last few months, due to there was approximately a 30% reduction because of better clinical interventions and management. And so that's good that they did it. And so this new projection that I've shared with you is based on that. And I just want to look here again. So this is what the model is forecasting states should be shutting down, just based on previous behavior that we saw in March and April, based on the number of deaths. And so when we look here in November, then the model is expecting that all of these states in this dark orange will be shutting down within a week or two. And so if they don't, then we're going to have far more deaths than we're currently talking about. Similarly, these additional deaths, including Connecticut over here, are expected to be shut down in December, if not sooner. And then by February, or rather January, we'll start to see, it's hard to see some of the differences, but by January, Pennsylvania, Maryland, some of these other states will start to also shut down. And so this country, there's this forecast is assuming that you see in green that there's not going to be any mandates before March 1st. I think that we're already starting to see curfews in some of these countries. New Jersey, New York have been talking about closing bars and restaurants after 10 p.m. and doing other things. I think that we're going to see more and more of those types of interventions, particularly in New Jersey and New York. In fact, while we're on New Jersey, let me share with you what New Jersey looks like, because New Jersey is an interesting case. New Jersey was hit hard back in March, April, May. And so some people thought, well, maybe we'd have some sort of herd immunity there. At this point, so many people have been infected in New Jersey. It's approximately 24%, one of the highest in the country in terms of the total number of people that have been infected. And when you look at New Jersey's curve, we're on an exponential growth curve now. We can't really compare the numbers in the current numbers in November 15th to the numbers back in March and April, because the diagnosis rate was far, far worse back in March and April. But so what we can compare is every few days, like a week over week type of analysis, because then the numbers should be much more comparable. And what you see is this exponential growth curve that we're on. So we're in trouble unless we do it. Hospitalization is still, this is more of a better comparison, looking at where we are now versus earlier in the year. And you see that hospitalization is starting to go up. It was taking it was slowly going up, but now the shape of the curve is now rising. So it's going to grow much more rapidly. And luckily the deaths in New Jersey have not gone up very much. All right, I'm getting pinged by Rebecca to switch back to questions. So Rebecca, I will give it back to you.
Yes, I did ping you. You weren't supposed to say that. Now everybody sees behind our curtain. Okay, so these maps are really frightening. Interesting to note, though, in the Northeast, the consortium of 6 states kind of working together. It'll be interesting to see what came out of the governor's meeting this weekend. I don't know if you saw, I haven't seen yet any reporting on that, but it looks like, I'm assuming that those 6 states will have more of a coordinated response that's less indicative of what this map shows, and sort of they'll go to the weakest link and then act accordingly, perhaps. I don't know. What do you think?
I hope so. I haven't been following that closely, but I hope you're right.
Yeah. So Sandy, if you don't mind unmuting, you had a very interesting question about the presidential transition?
Sandy, you're on mute.
Okay, here I am. Okay. I should really read what I wrote to Rebecca. What is missing from the lack of a transition from the current president to the president-elect regarding the updating of the pandemic? Doesn't President-elect Biden already have the resources that he needs to know pretty much what he needs to know? Maybe even more scientists have been gathered by him than by President Trump. But it's a little disconcerting that there hasn't been that connection yet.
Yeah, so I don't know the full answers. I did work for the federal government doing consulting work for a bunch of years. And so just based on that experience, I can tell you what I know generally, but I don't know the specifics about this. So basically, during a transition, these things are expensive. You need to hire people because you can't expect people to work for free because people have jobs or people have mortgages and they have expenses. And so the GSA, once the election is confirmed and validated and the results are confirmed, the GSA, the General Service Administration, is supposed to release millions of dollars, at least $8 million to begin with in the first, at the beginning, to start massively hiring, getting all the laptops, even just the infrastructure you need to start getting people on board. They're supposed to schedule meetings between the people who are going to be the new working in the FDA in the new administration versus the old, people working at the CDC, people working at Health and Human Services. All of these people at that level are supposed to be having daily meetings to get to know what's going on. And they've been prevented from doing that so far. So right now, all the mechanics of what's going on they've been prohibited from doing that. And there's the money has not been released. The agency heads have not been permitted to talk across the new administrations. And so that's extremely problematic because it's not just a question of having idealistic policies. You need to know, oh, well, if you want to get this done, you need to call John at extension 752. And they have no way to even talk to anyone. They don't know logistically what the map of the government looks like what's the org chart. Who do you call if you need this? Who do you call if you need this? They haven't exchanged the org charts, so you don't even know who you need to call. It's very problematic, and yeah, I don't know any much more than that. I mean, there's a lot of data that's available right now. A lot of the data is not harmonized, and so one state might be reporting one thing, another thing. I'm assuming that there's some behind the scenes communication that's going on, just because people who work at the CDC have their own networks and stuff, and I'm sure a lot of these networks are being engaged, even if it's not official. But that's all I can expect.
Are we in danger by him not knowing?
Well, I mean, you tell me. Here, I just shared with you the screen of the outbreak, and yeah, I mean, presumably, if this were well managed, our outbreak would be looking more like Europe and not like our states are currently.
Yeah, although Biden wouldn't be making those decisions right now, but.
Agreed.
Okay, thank you, Glenn.
Thank you, Sandy. Thank you for
You're
that question. So we're going to turn to Rachel, who had a question about the outbreak in the US. And there you are, you're unmuted.
Okay. Hi, everyone. Question for you, Glenn. What are you really attributing this big outbreak this week to? I mean, in my thought, I would imagine it has something to do with the election, whether it be the rallies or the protests, the celebrations. Like if you look at the states that had the most controversy or were unable to confirm their election results sooner, are you seeing more outbreak in those states, or is this just planned as in, it's cold now and we're all inside and fatigued?
Yeah, that's a really good question. Let me share this. All right. So I think it goes back to what we're looking at here, I think. So there's a few things. One is that the masks, people aren't wearing their masks. And masks are not just masks. Masks are very likely to be representative. It's a proxy for all the other things. If people are not wearing masks, then they're unlikely to be wearing, to be doing physical distancing and the other things that people need to be worried about. And so that means that this is part of the problem. The other main thing, and this is more than much of else that we're talking about. The other main thing is that flu-like illnesses and pneumonia and respiratory illnesses tend to occur every single year at around the same time. And that time, the typical flu season is November. It starts to really, I mean, sometimes a little bit earlier, October, it starts to go up. Some years it's a little earlier than others, but most years it's around November, early November, it really starts to take off, gets really big, December, January, February, March, and then by April, it starts to subside. And the same risk factors for why flu spreads like that, like it does, is exactly what we're seeing with SARS-CoV-2. And it's just following the same pattern. In fact, when we looked at the Southern Hemisphere, the Southern Hemisphere got walloped. Where is this over here? Oh, here it is. So the Southern Hemisphere, even though they had their disease under control, when much of the Northern Hemisphere was hit hard, back in the beginning of their, like, so I put, so the Southern Hemisphere, it's wintertime when it's summertime here. So I put here April 30th was for them the equivalent of what our October is generally in terms of seasonal. And you can see that around October, South America really started to go up high. By December, they were really, really high. Different, you see the different numbers here. This is because different countries reported different peaks at different time, and it just looks weird when you look at South America as a whole. South Africa tended to be doing pretty well. They were able to hold out to like November, but then December hit and they just went straight up. And so the problem was they shut down completely for a period, and that was the only thing that got them back down to where they were. Australia too had been doing amazingly well, and then even they started by January or so. Started to have it, and then they too shut down in order to keep it down. And they were, I heard people talking about South America during their winter as it made COVID-19 on steroids. Another reason for this is that, so what this means is that the R value goes up. And so the spread, for a variety of reasons, people spend more time indoors, they spend more time, the humidity level changes, and that makes a difference in terms of how much the disease can spread, other things like that. One other thing I'll point out is that we've known for a while now that the dose makes the poison. And so in this case, during our summer, our case fatality rates were going way down. So most of the Northern Hemisphere, the case fatality rates were going way down. I'll use this arm. And then in the Southern Hemisphere, they had been somewhat low, but then when their winter hit, it was just the opposite. Their case fatality rate started to rise. And that's because the more contagious the virus gets, because the R value is going up, so the easier it is to spread, there's typically more circulating virus. And so that means that your dose of exposure, the amount of virus you're exposed to, actually is larger in the winter than during the summer, typically, if the R gets higher. And so if this hypothesis is true, that the dose makes the poison and that its the case fatality rate could go up, this is consistent with what we saw in the Southern Hemisphere during their winter. So it could mean that not only is the virus spreading faster, but this could actually drive increased hospitalization and increased death. And so the infection fatality rate could actually end up going up again in our winter. But I don't know if that answered your question, but
no, I mean, I was just curious to see if there was any election, any rallying, or I was so nervous seeing on the TV all these people who are congregating, some wearing masks, some not. I was curious to see if it was just a terrible week as a result, or 2 weeks as a result.
Yeah, it could be, but the fact that we're seeing the spread in every state, pretty much, it makes me think that, I mean, that was part of it. There's a lot of things that are involved, though. I mean, that's part of it. But in addition, the holidays are coming up, and so the numbers are only going to continue to increase. All right, Rebecca, some really, really good news that we talked about this week. So let's hear it.
Before we get to the really, really good news, Deb had a question about flu. So Deb, I'm going to ask you to unmute, please.
Can you hear me?
Yes.
Yep.
Hi. So the question is, if people are wearing masks more than normal, like say it was a normal flu season, would that not reduce the flu even if COVID's going crazy?
Yeah, absolutely. In fact, we saw a global reduction in flu for the same exact reason. So when you looked at South America and Australia and other countries, there were far less flu cases this year than previous years. I mean, orders of magnitude less. It was almost like it was wiped out in some places, which is really exciting. And I shared the figure with you just now, just to show you the typical curve of what it would look like. But it's surprising that SARS-CoV-2 is spreading so rapidly, even with the masks and everything we're wearing. Like we're knocking out flu, yet SARS-CoV-2 is still rushing through the population uncontrolled.
We'll take that little bit of good news, right? I mean, let's take it.
That's good news. Oh, but there's much better good news we're about to talk about.
Move to that good news. Is it true that a cure was just announced for COVID-19? Why haven't we been hearing about this on the news? Tell us everything you know, please. Great question that came in.
So let me share my screen. So yes, we've talked about monoclonal antibodies for a while now, and I see this as a cure, or as close to a cure as we're going to have anytime soon. And so this is really amazing news. So let's spend a bunch of time talking about this, because I really want to dig in the details. I also want to talk about the Pfizer vaccine. So I need to balance this in terms of how much time I spend on it. But so let's start with this. So the problem is, okay, monoclonal antibodies, this is pure neutralizing antibodies. So what they do is they thought, well, if someone gets sick, what if we just give them, instead of waiting for them to develop their own antibodies and suffer, why don't we just give them a shot of pure neutralizing antibodies? Shouldn't this cure them? And so they have been doing trials. Lilly made one version of it. We've talked about Regeneron doing the other version. Regeneron gave their polyclonal antibodies. So there were a couple different monoclonal antibodies that were within one shot. And that's one of the key things that almost certainly saved President Trump's life. And so this thing is a miracle drug. And so what they found is that when they gave it to people early on in the disease, so when they only had mild or moderate symptoms, it reduced the amount of hospitalization and death. But hospitalization, at least, that's what the emergency use authorization is on, by over 70%. And so this is huge. Imagine if you were at risk of dying, you had severe illness, and now we have a drug available that's currently available that could reduce your risk of even needing to go to the hospital by 70%. So forget about your risk of death. Like, this just heals you, cures you, and you don't need to even worry about going to the hospital. Still, it's a bunch of people did need to go to the hospital. We don't know what their death rates or longevity were related to that, but I expect that it would be fairly good. The problem with this is that, well, there's a bunch of problems we'll talk about, but the first problem is that if the drug is given too late in the disease course, then it actually could make matters worse and actually make a person more likely to die from the disease. And so so what this means is that the drug can only be given to people who only have mild or moderate symptoms. And so let's talk about this a little bit more. All right, so it reduced by 72%. Regeneron's announced so far, reduced by 57%. Here's the key thing. All right, so this is potentially a miracle cure. The key thing is it needs to be given within hours or at most days when someone first gets symptoms. If you don't get the drug within the first few hours or days, the longer you wait, the less effective it is. And if you wait too long, if you wait to actually have any severe symptoms at all, then it's too late. So someone who has severe symptoms that make them need to go to the hospital, not a single one of those people can take this drug. So that's problematic. But everyone who is now hearing my voice, you now know this drug exists. So if you are in a high risk group, you need to immediately, at the first sign that you possibly have a symptom, you need to immediately drop anything else you're possibly doing and immediately run and get a PCR test, because you need to test for the virus, not for the antibody. So it has to be a virus test, and it should be something that you can get the results quickly. If the results don't come back for a few days or a week, you're not going to be able to get access to the drug. You need to get a test somewhere, a PCR test, and fight as hard as you can to get that PCR test. You need to ensure that you get results within 1 to 2 days. Because once you get those results, then you can get your doctor to track down this miracle drug and so you can get cured. So this is an amazing, amazing breakthrough. Your life could be saved now, but there's this major constraint that time is of the essence. The symptoms should be a trigger to immediately go and get tested, because once you have the first severe symptom and you might need to go to the hospital, it's too late. There's no cure. The drug will not work. All right.
Glenn, we have a question. Rachel just asked. I'm gonna ask the question just for the sake of time here. For you to define high risk and if those people automatically get it. And then additionally, I'm wondering if folks should jot down your Lily's 24-hour support line phone number. Thank you for including that. And I'll read it off for those who can't see. It's 1-855-545-5921. If people have questions about, are they eligible, where they can go to get this treatment, should they consider it depending on their symptoms, etc.
So I can answer many of those questions for you here, but that's exactly why I put the support line there in case people have questions. Again, the key thing before I go on, so I'll get into that in a second, your question. If you are sick enough to need to go to the hospital, the drug won't work on you. But there's one tricky thing about this drug, and it's an infusion product. It's not just a shot. And so that means that there's not very many places you can go to get it administered. You can't go to your primary care physician and just have them give you a shot. It has to be administered at a hospital or infusion clinic. So the paradox here is that the place you would need to go to get the drug is the very place that people who would normally go to that place wouldn't think to go to get it. And so it's a problem here. The other problem that we're going to see is that there are not enough doses to go around. So here's the list that you were just wondering about. Every single person on this list is eligible for the drug if they have symptoms and test positive for SARS-CoV-2. Every single one. This represents tens of millions of people in the United States in terms of people who meet these requirements. Probably more than tens of millions. When you add up, and in fact, let me read off what all the specific ones are. So someone who has a body mass index of greater than 35, what does that mean? So here's a nice chart that you can look at. So if someone is 5'10" and they weigh roughly 240 pounds or so, is that it? 240 pounds, then 35 is right around the cutoff. So if they're roughly 245 pounds or more, and they're 5'10", then that means they are eligible for this drug. That is a BMI over 35. So you can look on your screen. I'm sorry that the numbers are so small, but you can look online to see what your height is and your weight to see if you qualify. But by over 35, we're really talking about people who are obese, heavily overweight. But some people might be obese and not even realize it. So for instance, as the height goes down, like someone who's 5 foot, their numbers only need to be 175, 180, or closer to 180. What is it? Yeah, so like 175 or so, which is very heavy, but they might not realize that that would put them at an even higher risk category. All right, I'll let you look on that at your own because there's a bunch of other categories that we're going to look at. All right, if someone has chronic kidney disease, that makes them eligible. If they have diabetes, even possibly metabolic syndrome, they'd have to talk to their physician about that, about the specific criteria and whether they should be considered with their risk levels that they would qualify for this drug. If they have immunosuppressive disease, if they're currently receiving any immunosuppressant treatment at all. So for instance, a lot of immunomodulatory drugs might count there. If they're age 65 or over, so anyone age 65 or over, simply by being that age qualifies for this drug. And the more comorbidities you have that qualify, probably the more likely you are to receive the drug. But there's other risk factors too that people can have. So if someone's over the age of 55, then they need to have one of these other risk factors too. And so if someone's over the age of 55, they need to have either cardiovascular disease or hypertension or COPD, and that would make them high risk and someone that should be on the drug. If someone other than that, if someone's between the age of 12 to 17 and they're obese or under this a very specific definition of BMI that they're using, or they have sickle cell disease or congenital or acquired heart disease, neurodevelopmental disorders, for example, cerebral palsy, or a medical related technological dependence, for example, a tracheostomy, gastrostomy, or any of these others, or they have asthma, reactive airway, or some of these other things that require daily medical control, then they are eligible. So this is the full list of eligibility. You can check online to see it, but I've put the full list here from the emergency use authorization.
Glenn, we've gotten a question. Sandy asked, would it make sense for anybody who's high risk to make those calls now to find out what infusion centers, what doctors have this treatment?
Well, the problem is, so here, I don't know. So yeah, I have a bunch of slides on this. So the problem is there's only a limited amount of drug available. Under Operation Warp Speed, the US government has purchased 300,000 doses from Eli Lilly. There's going to be more coming from Regeneron, presumably when they get their emergency use authorization within the next week or two. And so right now, I think under this, the US government has maybe 70,000 doses. The way that the distribution and allocation will work is that they're going to allocate it based on the level of SARS-CoV-2 at the state and territory level. Then what they're going to do is they're going to contact the states. Then the state health departments will themselves determine where their allocations are going to go for the facilities in their jurisdiction. And then it's going to be distributed to those facilities directly by the company. What this means is that the allocation might vary from state to state on a weekly basis. And then within that, the amount of product might vary by facility based on what the health departments decide, where the cases are going, who's being hospitalized, et cetera. So it might vary tremendously. Knowing today where the drug is won't necessarily tell you a week from now where the drug is or what facility has it. And so this is going to be something we're going to have to keep an eye on, and it's going to be hard. There's a few other things I wanted to talk about here. Who should not be getting it? All right, so like I said, once someone is hospitalized, it is too late. They're ineligible for the drug. If someone requires oxygen therapy, even if they're not hospitalized, it's too late. If they require, and so basically, if it's not within the first day or two or a few days, it's just going to get, and the symptoms start to progress rapidly, it's just going to get really hard to get the person on therapy. A couple other things. One thing to remind people, what are the symptoms to be looking at? All right, so here are the key symptoms to remind everyone. Fever, new or increased cough, new or increased shortness of breath, chills, new or increased muscle pain, new loss of taste or smell, sore throat, diarrhea, vomiting, fatigue, headache, nasal congestion or runny nose, or nausea. If you get any of these, then you should immediately rush to get a SARS-CoV-2 test. And if you have multiple, then it makes it even more likely. One quick thing before we move on, I just wanted to say that the positive predictive value, just because you have a symptom does not mean, let me send this to the front, does not mean that you have SARS-CoV-2. In fact, the vast majority of people with a cough are not likely to have SARS-CoV-2. So for instance, here is an example of a study where they looked at people who were positive with SARS-CoV-2 and people who ultimately ended up being negative with SARS-CoV-2. And when they asked people who had a cough, although 71% of people who with SARS-CoV-2 had a cough, that represented only 59 people. Yet when you look at the total number of people who had a cough, 59 was only a tiny fraction of the total. There were in total 365 people with a cough. And so 59 was only a small percentage of those people. So having any of these symptoms does not mean you have SARS-CoV-2. In fact, most likely, if you have any of these symptoms, you do not have SARS-CoV-2. That's why you immediately need to go and get a test. Make sure when you go that you keep your mask on and that you keep your physical distancing and whatnot, because there's a very good chance you don't have SARS-CoV-2 and you don't want to get infected. But at the same time, so it's a reason to go and get tested, but it's even just having a symptom doesn't mean that you are likely to have SARS-CoV-2. So let's just keep that there. All right, Rebecca, let's go on because I know it's getting late. We can stay a little bit later today because there's the Pfizer vaccine, Thanksgiving, and a couple of things people might want to talk about.
Yeah.
Oh wait, one other thing before we go on. One other thing. Sorry to drive this home. I don't know if you all remember the movie Cocoon from in the 1980s. Remember that pool that was magic essentially, where if you went in the pool, it gave you this, it made you 30 years younger and gave you this life-enhancing property. But if you waited too long and didn't go in the pool, then it was too late. And so don't be this guy. He waited too long, and then when his wife needed to get rejuvenated, it was too late. All right, Rebecca, back to you.
Great movie. I remember watching that with you back in, let's go with 1982. I don't know. Maybe someone in our audience knows the right answer.
Oh, I wasn't born back then. I don't know about you.
Yeah, I wasn't either. Okay. So we are getting close to our hour together. So yes, we do have a lot to cover, but what I'm going to suggest is that we talk next Sunday about family and friend gatherings for the holidays. So let's push that till next Sunday, and we'll talk about carriers more next week. But we for sure need to hear from you about this Pfizer vaccine and any other vaccines in the pipeline and what we can expect in the coming days, weeks.
One thing, okay, we can keep the discussion of Thanksgiving until next week. There is one thing that I need to tell people now, though, just before we go on, and that is, let me see if I can find it. Let's see where I put it. Just real quickly. Oh, here it is. All right, so it's this idea. If you want to spend time with family or friends at an event for the holiday for Thanksgiving, you ought to go into quarantine for the 10 to 14 days prior to the holiday. Anyone who could possibly at risk, who you might want to see, anyone you know, 10 to 14 days quarantine before, then you don't, that's the only way to ensure that you will not risk getting anyone else infected at the holiday. So make sure that we're right about that window now, 10 to 14 days for Thanksgiving, you need to go into quarantine right now. Make sure you do not expose get sick, or if you are sick, that you can find out that you have the symptoms before then. All right, now let me go to the Pfizer vaccine. All right, the Pfizer vaccine. Wow, so great news on this end. Now we have the vaccine. The first vaccine has been announced. So let's jump right in here. What do we know and what don't we know? All right, here's what we know. Almost 44,000 people have been given the vaccine. 94 people have become infected with SARS-CoV-2. The vaccine has been reported as being 90% effective or more. This implies, if you put these numbers together, that there were approximately 85 people infected in the control group and approximately 9 people infected in the vaccine group. This is all that was reported. This was not a scientific report. It was not a peer-reviewed journal report. It was a press release that was given. So there is a ton that we don't know here. So I'm going to go through the specific things that we don't know before I go on further in terms of the descriptions of the things we do, because there are some really severe constraints on what we know. First, does the vaccine prevent severe disease, hospitalization, or mortality? We have no idea. It could be the case that the vaccine only prevents mild or moderate symptoms. And in that case, who cares? If it doesn't prevent severe disease, hospitalization, or mortality, this is a critical thing I think that we should find out. Right now, this hasn't been reported at all. Just as a point of reference, I've mentioned this previously, if I can find it. I just want to share. Nope, I'm not going to be able to find it too quickly. Well, anyway, I was going to share with you the flu vaccine. We've talked about this previously, that the flu vaccine, here it is, it's very next slide. The flu vaccine has been found that it could provide this herd immunity, protective herd immunity by a lot of people getting vaccinated. However, a recent study that was just done, it's been a controversy out there for a while. This study was published back in April, and there's a lot going on in April. A lot of people might have missed it, but there's currently not strong evidence that the flu vaccine for people ages 65 and over actually reduces hospitalization or mortality among people over the age of 65. This is huge. Everyone takes the vaccine because they think it's reducing hospitalization and mortality, but it actually turns out it may not be the case that it's reducing hospitalization or mortality. When it comes to this vaccine, this is something we urgently need to know, because if it doesn't, and people start get vaccinated because they think it does, then this is going to be a real big problem for society, because then we might actually do more harm than good. Because if people get vaccinated and take off their masks, go back to the bars, start partying like it was 1999, then guess what? We could actually be in a much worse situation, and we might see a lot more hospitalization or mortality than we were expecting. Next question, does the vaccine prevent SARS-CoV-2 spread? This whole idea of protective herd immunity is that once someone gets a vaccine, they can no longer be contagious. They're like, the idea is that they're a wall and they can't infect anyone else. However, if people with this vaccine just become asymptomatic but still contagious, this would be an enormous problem, because then this actually doesn't adjust anything with the herd immunity question. Instead, all you're doing is all these people who maybe would have previously had mild or moderate symptoms, they might just be asymptomatic but still be contagious now. This could be really problematic. We don't know this yet. They haven't communicated this. We haven't seen the data. Next, are there antibody-dependent enhancements? We've talked about this previously. I'll talk about it in a second. We don't know yet. They haven't reported, and we won't even know it because this is something that you wouldn't see until a lot more people were infected, and then you see how many people with who were vaccinated had more severe symptoms. The problem here is that, so we've talked previously that some people were found to be reinfected. So for instance, there was a guy in Spain that was found. There was a guy in Nevada, in Las Vegas, that was found. There were other people who have been found to have been infected twice, and being infected the second time actually makes them more likely of being hospitalized or of dying. So the first time might have been only a mild symptoms, but then if they got infected a second time, it makes it worse. Protective immunity isn't supposed to work that way. And so if this is an example of an ADE, of antibody-dependent enhancement potentially, and if this is something that we need to be worried about, then we need to be investigating this in the vaccine. And there's been no report coming out yet on this. Does the vaccine protect people over the age of 65 or other at-risk people the same way that it's reported as protecting the people infected? We have no idea. Currently, it hasn't been reported. Does the vaccine protect kids? Again, no idea. How long will protection last? That's something we don't know yet. This one doesn't bother me as much. The other ones would prevent me from wanting to take the vaccine at all, or to recommend people take it. But if protection doesn't last very long, that doesn't bother me so much. If you need to get a booster shot every 6 months, we could deal with that. Will use of a partially effective vaccine lead to riskier behavior that could outweigh the benefits? I just mentioned this earlier. This is a serious concern if it doesn't have the protection that we're really most concerned about. Will early adoption of the Pfizer vaccine, simply because it's first, decrease adoption of vaccines that may be better but are still in the pipeline? This is a serious question a lot of epidemiologists are worried about, and so maybe we shouldn't be rushing out for the very first vaccine that's only based on 94 people being infected. Next, will the emergency use authorization make it harder to recruit people into other vaccine studies? There's a bunch of other vaccine studies going on. If you wanted to get a vaccine, why would you volunteer for one of these studies? There, in those studies, you maybe a 50-50 chance of being given a placebo. Whereas if you go for the Pfizer vaccine, you'll know for sure you got the vaccine. So will recruitment be hurt? I don't know yet. Here's a question. Why aren't 100% of vaccinated people protected from COVID-19? So there's a bunch of reasons typically that vaccines don't protect 100%. One of them might be there's variation in the distribution of genes or whatever, in terms of the different mutations that might be occurring in a virus that you might get a vaccine for. There may be different amounts of antibody produced by different people. There's all sorts of reasons. But I'd really like to know if Pfizer's looked at this and can help to inform us in terms of, well, how can we interpret this? And this is related to this question, is there a correlate of protection? Do higher levels of antibody provide more protection? And so by this, if someone's vaccinated, could we just look at how much antibody, do an antibody test then to see what their antibody levels are and see, is it effective, or do they need to assume that it hasn't been effective for them? There are tons of questions we still need answers to. Those are the main ones. I am cautiously optimistic. So I'm not just intending to just throw this out. I'm optimistic. I'm cautiously optimistic. But right now, there's a lot that I need to have answers to before I would recommend anyone I know getting the vaccine. Let me go into a few. I know we're getting late in time a little bit. So the protocol, I'm not going to go much into that. We discussed that. Oh, here's the other thing. Vaccine distribution logistics. All right, so there's three major issues with this vaccine that are different. The first thing is that it needs to be kept at temperatures as low as -100 degrees Fahrenheit. Let me say that again. Freezing in Fahrenheit is 32 degrees Fahrenheit is freezing. 0 degrees Celsius is freezing. 32 degrees Fahrenheit is freezing. This needs to go below -100, or roughly -100 degrees Fahrenheit. I'll just wrap it up just shortly. Let me just continue this slide and one other slide. So that's really cold. This is so cold that the glass vials themselves that are normally used will break, and you can't use those to store it. Our distribution is not set up for something like that, and even the freezers. This is not something that primary care physicians are going to have in their office, where you just have a freezer that you can just go to your doctor and get. We're going to have to go to other places, and the distribution is extremely logistically complex. Luckily, there's answers. So FedEx and UPS are working on distribution, on the distribution logistical issues. They're setting themselves up for success, and they have the logistical. They're in place where they need to be. The glass vials. So Corning has been working on making specific glass vials just for this purpose that can withstand the cold temperatures. I think they're on target. There's been a shortage of dry ice. A lot of people haven't been hearing about this, but now we require a massive amount of dry ice. So people have been working on on that specific logistical challenge. So luckily, despite the logistical challenges, there's still people working on it. Luckily, Moderna's vaccine, which is based on the same premise as Pfizer's, only needs to be kept at -20 Celsius degrees, as opposed to Pfizer's -80. So luckily, once Moderna's comes out, and then hopefully AstraZeneca and Oxford's, we don't need to have the logistical constraints become far less important. Just one other thing. Some people were asking, how does a mRNA virus vaccine work? So an mRNA vaccine works by actually putting RNA into the cells. So you just, by the injection, the RNA will go around the body, get taken up by the cells, and then it will program the body to make protein. And so this protein is what's excreted. The protein is the S protein, and it's this S protein then becomes the antibody, or rather the antigen. So it becomes just the part of the virus that the antibody will respond to and develop around. All right, I know we're getting late on time. I'm going to stop it here. We can revisit this next week. And so great, there's a lot more to talk about here, but hopefully this is enough food for thought to keep you covered for the next few days.
Yeah, definitely. I wish I paid closer attention in biology. Clearly you did. So thanks again for paying more attention those days and sharing, reminding us how the vaccine works. That is helpful. So let's begin there. I'm sure between now and next Sunday, there will be much more information on these vaccines. Well, let's hope. And hopefully at least some more answers to those great questions you asked. Goodness, I didn't even think of most of those questions as being questions I would ask prior to taking this vaccine. So I think that would be a great place to start. And then we'll talk about family gatherings and all of that. Okay, so
Thanks, Rebecca. The one thing, again, if you plan to get together for Thanksgiving or other holidays, you need to be going into quarantine now. If you don't go into quarantine, your risk is going to be very high during Thanksgiving, and it's going to be too late the next time we talk. This is the time. The date currently of this recording is November 15th. You need to immediately go into quarantine if you plan to get together with family and friends for a big event for the holiday.
great advice. Thank you for all of your great advice, all of these many months. We really, really appreciate you being our COVID tour guide and look forward to being together again next week. Everybody be safe, healthy, well, wash your hands and wear your masks.
Thanks, everyone. See you next week. Have a great week. Bye-bye.